Welcome to the Dr. Raj Podcast with Dr. Raj Dasgupta, a show all about educating patients, students, and aspiring doctors about better patient care. Dr. Raj is a quadruple board-certified physician and associate professor at the University of Southern California. He was a co-host of the TNT series Chasing the Cure with Ann Curry, as well as a regular on the TV show The Doctors. And now, here's our show.
Hi, and welcome to the Dr. Raj Show. Once again, super excited to be here. And this is actually going to be the first recording of 2021. So hopefully this is going to be a great year. Needless to say, it's been a tough year for everyone when we talk about 2020. So let's start off the new year on a good note. I have amazing guests today, and that's right, everyone. I kind of said guests, plural, because I got two amazing women, So let me kind of say a little something about them before we kind of do the introduction. So I want to do something that represents the Dr. Raj Show, which is down to earth. It's not all about dorky medicine. It's about being human and, of course, trying to get a good message out there. So I am very fortunate to work with two amazing respiratory therapists. And the problem is I can't separate them because they come as a package deal. And I'll be the first person to say that, when I come to work in the morning, these are probably the two most important people, fun people I like to interact with. We like joking with each other. Yes, we like teasing each other. We give each other hard times. But I think that they have a very unique perspective when it comes to treating patients with obstructive sleep apnea, because I always say that my job is the easiest. Just go get a sleep study. But they're the ones who are hands-on with the patients. And another reason why I love these two so much is because I'm going to let everyone in on a secret. Every time Dr. Raj goes on TV, I do practice. And these two are my two favorite practice buddies in the whole world. And I make them listen to me, whether they like it or not. So they're amazing. And so I'm going to introduce you guys now. One is going to be Chelsea. Do you want to say hello over there?
Hi, everyone.
Lily, you want to say hello?
Hi, everyone.
All right. So we're going to do Chelsea first, and Lily, you're going to chime in. So, I told them to give me their resume, but they just want me to ask some questions. They're going to do the answering on this. So, hey, Chelsea, where did you grow up?
I grew up actually in the San Gabriel, Pasadena area, so I'm local.
Cool. And where did you go to college?
So I actually went locally to Cal State LA.
Nice.
And I originally majored in psychology there, and here I am doing something different.
Well, let me just take a step back. How does one go into psychology, then suddenly say, I like the lungs better and let me help people breathe? I just don't see the connection there, Chelsea. What happened?
So I got into psychology. I graduated. I worked at a psych hospital for a little bit, and I realized that I wanted a more hands-on approach than what I was doing. So then it kind of went, am I going to go into nursing? That was something I was considering. And then respiratory therapy. I had actually some friends that were in respiratory therapy. They were respiratory therapists, and they talked to me a lot about it. And my grandma actually got diagnosed with pulmonary fibrosis, which I didn't understand a lot about it at the time. And so, as I talked more and realized that maybe I didn't want to actually pursue nursing, but I wanted a more hands-on approach, respiratory therapy came up, and I just became more interested in learning about the lungs and the heart. And
I like that. Now, respiratory therapy is actually very broad if people don't know that. And there are so many places in the hospital we need you, especially now during COVID-19. So why sleep medicine? Don't get me wrong. I am so pumped that you are one of my sleep respiratory therapists. But how did you choose sleep instead of, per se, being in the ICU or doing outpatient or focusing on a disease like cystic fibrosis? How did you make that decision?
Well, to be honest, initially it was the first job that I got out of school. That's the real story there. But I ended up, as I got into it, I actually became very fascinated with sleep and kind of, because it is so broad. So feeling like I was good at something and learning so much every day about it. And learning the implications and of everything of the sleep disorders out there, I got more drawn to it, and I felt more comfortable, and I feel very knowledgeable in it. And I find sleep very fascinating.
And not to mention, rumor has it there, Chelsea, that you yourself think that you have sleep apnea. Is that a true rumor?
That is a true rumor. Yes, I snore.
And someone told me that you go around with your snoring on a cell phone and throw it in the doctor's faces. Is that possible?
That may be possible. Yes. Yes. I may have asked you that.
All right. Let me talk to Lily. Lily, where did you grow up?
I grew up in Pasadena, Doherty area. I moved to Doherty right around middle school. Also went to school locally. I was at Citrus and got my associate's degree there. Was going to start working on my bachelor's, and then same thing. Chelsea and I actually started school at the same time.
Wait. You both went to respiratory therapist?
Yeah, we went to RT school together. Yeah. We both worked at the psych hospital. I worked at the psych hospital most of my life, actually.
Okay.
I started working there when I was like 16, and I was there for like 15, 16 years. And actually, that story is a little bit funnier than what Chelsea led to. We were actually on our way back from Vegas in a car full of respiratory therapists, and we expressed that we wanted to do something different. We wanted to kind of get out of the psych field and, like Chelsea said, be a little bit more hands-on in the health field. And they painted a picture of RT, and we decided to go for it. And we actually went to school together. So we've been stickies for a long time.
Yeah.
Now, I got to tell you, Lily, how do you go from, psychiatry, psychology, and, how did you switch the brain and emotions and depression, anxiety to let me enjoy the lungs? I mean, was it just...
I was in a different field than like patient care in psych. I did more the administrative portion of it.
Okay.
Still very involved with patients and whatnot, but it was the same thing. It was kind of like I had reached a point where am I going to go from here? Like, what more is there? I was an assistant business office manager at the psych hospital, and I was like, well, I'm not going to do much more. So what's next? So it kind of just came down to that, and I needed to do something else. And so
now, once again, I love that you're here with me doing sleep medicine. So of all the broad things that a respiratory therapist can do, why sleep?
Well, again, it was my first job.
You guys are hilarious.
But this is the thing. Nobody tells you when you're in school, when you get out of school, nobody tells you like, hey, also when you go apply for a job, they're going to ask you how many years have you worked in an ICU or an ER, and your response is going to be 0 because I just got out of school. So it's really hard for someone to give you a chance. You have to get really lucky. And so we really just got our license, and we just kind of wanted to start doing literally anything. So we ended up in sleep, but it actually did become, it has become our career.
So let me ask both of you this question. I'll be the first to say that, I love all my respiratory therapists, and even if they're yelling at me or they don't trust me or they give better advice, I think they're amazing. They've been so great during this pandemic. And even my outpatient respiratory therapists, they have so much experience. So my question to both of you is, for people in the field, when they're going to graduate, what advice do you give them so they can make a decision of what part of pulmonary medicine they want to go into? What is some advice you'd give these people?
It's really hard to say. Be really persistent. I mean, if that's kind of like, if you want to go into the ICU or an ER, just continue to apply for those positions. It might take a little bit longer. With us, I think it was like a different dynamic that ended up playing, the role that sleep ended up playing in our lives, because we actually both got really into it. It was a lot more interesting than what we initially thought it was going to be. We said, okay, we're going to go into sleep, be in here for a year, and then start getting jobs in ICU, ER, blah, 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 blah. That didn't happen. But we ended up at USC.
Fight on, man.
Yeah. I don't think that we expected to sleep as much as we did. It was definitely just going to be a transitioning point. But to answer the question about what I would tell them is, if you're really interested in, now it's kind of different with COVID going on. There's a lot more jobs out there right now if somebody's newly graduating. But I would definitely say volunteer. And
I like that. that.
Volunteer at these places so they know who you are. Make yourself known when you're going to these hospitals for your clinicals.
Jill's great advice there. Now, I'm going to give just one extra shout out to Lily so everyone knows. Lily, I know for a fact that you recently had a wedding. Congratulations on being married. How does it feel that you're part of the team? Now you're part of the marriage team.
It feels great, actually. It feels good. It's different, but it's good. Really good.
I know you're just dying to talk about your husband snoring, but can we hold off on that for a little bit?
Absolutely.
Okay, I can see it. I don't see you, but I feel that little anger inside when I talk about that snoring, But
it's cute.
So everyone, I asked Chelsea and Lily what do they want to talk about today, and they were great. I wish we had video here. They had this whole typed piece of paper up. They were so professional. I want to talk about a couple things. So, what is the story behind the story? When many people have obstructive sleep apnea, the reflex treatment is always CPAP, continuous positive airway pressure. And, once again, it's easy for me to say, hey, use the mask, here's your CPAP. Chelsea, what do you feel is the main reaction when you see the first-time patient who gets diagnosed with obstructive sleep apnea and they have to wear the mask? What is their initial, are they shocked? Are they upset? I mean, what do you see in the trenches?
Mostly, I would say that they're shocked. You have a few people that are kind of desperate out there and want it and have heard about it, but I think it's mostly shock that they have to wear this Darth Vader looking like mask on their face. I mean, they're just like, you expect me to wear that?
Well, how do you keep on going, Chelsea? How do you address that then? Let's say I'm the patient. You want me to look like Kylo Ren, another Star Wars character. What can you do for me, Chelsea?
I try to explain to them because one pushback I get is, well, I've been sleeping this way my whole life. So I stopped breathing at night. That's not the biggest deal. I'm still here. I'm standing. My own grandfather actually said the same thing. And my response is the health implications, which I want to divert back to you, but I think it's very underdiagnosed, unfortunately. And most people think that I just live this way. They blame it on busy lifestyles. And I think learning the health implications. So that's what I try to explain is, that it can cause AFib, that it can cause high blood pressure, diabetes. Yep. I mean, the many different things. So, okay, you're okay right now, but in 10 years, you may develop a heart issue.
No, I like that. And, and I'll say this to both of you, that you stole one of my techniques. I think that what's the long game and the short game is everyone always asks, can you die from, untreated obstructive sleep apnea? The answer is sure. I mean, not being treated means like being sleep deprived and you can just crash on the highway. But the other side is the long game. And I think, Chelsea, you said it great. Atrial fibrillation, high blood pressure, poorly controlled blood sugars. Lily, what about you? How do you address it when someone comes in and, and they're shocked that they can't wear the mask? And let me ask you another question on top of that, which is, what mask do you offer them? Who gets a full face? Who gets a nasal pillow?
Sure. So same thing. I try to do like a in simple terms explanation for patients. Usually I go with the good old, you're not getting oxygenation when you sleep, and that's working your heart muscle. They tend to respond well to that because unfortunately, no judgment towards the MDs, but it does take a long time to sit there with the patient and explain exactly, hey, this is what you're doing to your heart. This is how you're wasting that good muscle. Don't do that to yourself. So it's more of explaining the health issues that are going to come along in 10 years. Some of our patients, we do get patients who are in their late 20s, early 30s, and, they're young, they're strong, and they think, I have a busy lifestyle. I go to school. I work full time. I have, I'm married. I have kids. It just is what it is. But I always tell them this, do you want to watch your kids grow up? You want to, be able to see your grandchildren. It is, like Chelsea said, it's very underrated.
Let me ask you this and interrupt you. So who is the biggest pain in the behind? Is it usually the young folk that come in there or is it kind of the older patients who are like, you know what, I lived this 80 years without something like this? Who gives you the most problem there?
It actually goes both ways because we do have the older generation that will tell us, hey, I'm 70 years old. I've never had I've never had to sleep with a mask on my face. And all of a sudden you want me to put this mask, and not only put this mask on, it's going to push pressure down my throat. Basically, we get pushback from them. And we also get pushback from younger people too. Chelsea actually has a good story about this.
So I did a CPAP visit a couple weeks ago, and the patient had her CPAP for 2 years and only used it for a week. But now it is really bothering her again. And I asked her, why did you not use it for, the first 2 years? And she said, well, to be honest with you, I was dating somebody and I did not want them to see this mask on my face and know that I had sleep apnea. I was completely embarrassed. She said, now I've been with this guy for 2 years and I feel we're comfortable. So I'm okay with him knowing that now. But at the time, that was not good.
So Chelsea, what was your reaction when you heard this story? Did you have to play the I understand, you know what I mean? Or did you?
Absolutely.
Definitely, because I actually do understand, I understand for the younger people, or even females. Yeah, that's, it's kind of more you attach that to a male. So being a female and, having to do that is difficult. So I told her I can understand that, but I tried to tell her, hey, but you will feel so much better. You're not going to be exhausted every day. You're going to be able to enjoy your time with this partner. And she actually said the snoring's driving him nuts. So I said, well, would you rather be a snorer or?
And it sucks because it's socially acceptable, I think, for males to snore. Yeah. And it's socially acceptable for them to have to go get a CPAP. But, women do react a little bit different.
Yeah.
It's like
that is true. And I'll tell you a quick little thing that I felt in my years doing, seeing sleep patients, that it always seems that anytime, the wife is snoring, the husband's always so quick to report them to the sleep doctor. They just can't wait, But let me ask you, both Lily or Chelsea, give some advice to the men out there who have obstructive sleep apnea who are single. So let's say there's a make-believe patient who's 40, 45 years of age, on that dating wagon, trying to find the right person to commit to. And they finally find someone. And how would you suggest they bring the CPAP device in the bedroom? Is there a way to do it? I mean,
I don't think there's going to be a sexy way to do it. I think the more educated you are on your health, the more you're going to be able to tell this person, hey, also I have sleep apnea, and actually, be upfront with your health issues. You can't just cause your health issues just because you don't want to look like Darth Vader.
Well, let me get this straight, Lily. So your advice, and Chelsea, chime in here. Lily, you're saying day one, even if you're on first base still with the kissing, bring out the CPAP machine.
If they're spending the night, bring out your CPAP machine.
First night. All right. Wow.
If they're spending the night. If they're not spending the night, then they don't have to know what you put on your face when you go to sleep.
All right. Chelsea, do you agree? First spend the night, take out the CPAP machine, put the mask on.
I'm gonna say hook them in for a couple months, maybe. Make sure that you get that hook and that they're really into you after a couple months. And then,
but what do? You don't wear your CPAP?
It's a tough call,
It is. It's tough.
You shouldn't. So hopefully they're not living with you at this point, and you can skip it first couple times and then be like, and then I think you do have to be honest. You cannot sneak a CPAP into the bedroom.
No,
you got it.
I think that, the hard part is finding that sweet spot, because I feel like, and now that Lily's part of the marriage posse, that, many things just come out after you're married. You know what I mean? Next thing you know, you're passing gas in front of your loved one, and, and then next thing you know, where did the CPAP mask come from? So I do believe there has to be a point where you start revealing these things. It's not after you've, done your vows that you bring all the things out there. But if you ladies could think of a good way to bring it out there, I'd love to share that with all the listeners.
Yeah.
Now, what about this? You two, answer me this. I don't care who answers. What about for my patients who are claustrophobic? What do you tell them?
We definitely try to avoid a full face mask for the patients that are claustrophobic. And I have noticed even, doing the sleep studies at night, the full face mask for people that are claustrophobic is just too much. And they even sometimes get panic attacks when you put it on them. I've had that happen. Nasal pillows, I think, is the best thing we can try for somebody that has that because it's small. Even the nasal mask sometimes is too much for somebody that is claustrophobic. So I think that nasal pillows are the best answer for a CPAP user that is claustrophobic.
Now, are there some patients that may still be a little claustrophobic even with a nasal mask or pillows?
They still may have that, unfortunately. And one good piece of advice I think that we give out during our CPAP visits and for education with it is to try to wear the mask while you are awake for 2 hours.
Yeah.
Watching TV, reading a book, knitting, whatever your hobby is to
be awake and alert.
To adjust. That way your brain and your body gets used to this foreign mask on your face and this pressure.
So should we put a part of our dialogue, Chelsea, when you're watching The Mandalorian, please wear the mask?
Yes.
So the only thing that kind of sucks about our claustrophobic patients, though, is their mouth breathers. And you had asked earlier what kind of masks we recommend. When they're mouth breathers and they're claustrophobic, we do have a new mask. It's called an F30. And
F30. How do you describe an F30 over podcast?
So it doesn't, like a full face mask will hover over the bridge of your nose. It's kind of like a big triangle. It covers your nose and your mouth. The F30 will not hover over the bridge of your nose. It kind of lies like on your nostrils, and then it does cover your mouth. But I have had some patients tell me, you know what, I don't feel so trapped like a full face mask that's covering from the bridge of your nose and all around your mouth.
And I don't think when we started sleep, that was actually an option. So it was kind of just like you have a full face mask, you have a nasal mask or pillows. And this is kind of a great in between that, it feels the full face mask is too bulky. And I could see how somebody would actually really feel claustrophobic with that. This is definitely less invasive feeling.
Now, either or, expand on this. You wrote down on my little list of things to talk about shutting off the power. So is the fear more of the patient, like pulling out the cord? Is it the fear of the power shutting off? What have the patients told you? What do you mean by that?
So this was actually my mom.
Oh,
who
be a good story already.
Yeah. Who I was like, you have sleep apnea. Like, I know this from living with you in the past. Like, you definitely have sleep apnea. And she's like, well, I don't want to go get a CPAP machine because I'm afraid if the power shuts off at night that I'm going to just die, that I'm going to suffocate basically. And so I had to, and then I come to find out as I worked in it that other people have this feeling too, that they're scared if the power were to go off. And I've actually had people tell me, well, if my CPAP shut off and I felt like I was going to suffocate. And so I do explain that is not the case, that there is safety measures in place and that will not happen. And luckily, I have to report my mom is now a CPAP user.
Oh, she is a CPAP user.
Oh, yes.
Oh, she's going to love this podcast. Hi, Mom. How are you? So I like this next question. Lily, you can start off. Chelsea, chime in. People think they're getting oxygen versus pressure. Now, I like that because, when, like I said, my pet peeve is I'm giving you CPAP. And I try to explain that CPAP is the way we're delivering this pressure. It's not the mask. But many people still have a misconception of really, is it oxygen? Is it pressured air? Is that a common thing that you're hearing, Lily? And how do you address that question?
It's very common. And to be honest with you, sometimes people just love the idea of getting oxygen. They are all about it. So I will have to admit, sometimes there's just, even if you try to explain pressure, they're like, oh, the oxygen. I'm like, sure, why not? The oxygen. I mean,
you try to correct them, but I even think we once had a patient that was using oxygen, his mother's oxygen, for his sleep apnea, because he's like, well, that's what you give when that's the treatment for it. And I was like, no, you cannot just be giving yourself oxygen.
It's pressure that's opening up
your
airway. But they people love to hear that it's oxygen. But yes, a lot of people do believe that it's.
And, from a physician standpoint, we definitely have patients who not only require a CPAP device, the pressure, but have oxygen on top of that. Yeah, and right. Trying to convey what you're talking about, it gets a little confusing. I mean, I don't know if you feel that also.
It can.
It definitely does. And, I think it's a really tough thing to explain. There is just kind of I think some doctors just prescribe the CPAP to the patients, and they don't really understand what they are getting or the process of it.
No, I agree. I think that, some diseases, and I think, Chelsea, you mentioned atrial fibrillation, untreated obstructive sleep apnea is such a huge risk factor is that many doctors will just order a sleep study because that's part of their workup. Don't really explain what a sleep study is, then, patient hits the jackpot, has severe sleep apnea, and all of a sudden you put a mask in their hand. They're like, what's going on? Yeah. So what's one thing that you feel can help out in patient education? Is it spending more time? Is it having videos available to them? Anything you feel that we could do, we meaning not just me, but just healthcare in general when it comes to obstructive sleep apnea?
Absolutely. I think that taking more time to explain and maybe just a simple video, but I think that you're absolutely right about a cardiologist ordering a sleep study. The patient I'll be like, why are you here? And they're like, I don't know, like cardiologist sent me.
Yeah. But I think we need to figure out a simple way to explain how harsh untreated sleep apnea really is.
Yeah, I think that, again, patients don't understand. Well, I have AFib, so I don't understand why my doctor's sending me
it's
here.
Related. Yeah, they don't understand the relationship.
Well, tell me this, I think one of the main things about sleep apnea is about being compliant, and I'll definitely say easier said than done. In both of your opinions, what do you think is the main reason why patients aren't compliant? What do they reveal to you when I'm not around?
Lack of education is going to be one, especially
lack of education after all this.
Absolutely.
That is the number one biggest issue I have when we get these patients for our CPAP clinic. It's just shocking what they believe or what they just have no idea that they have in their hands.
Even simple things like the way we watch them put on their mask, and we're like, okay, well, that's why it's not comfortable. It could be that plain and that simple.
So you guys tell me. So one thing I'm very proud about, here at our sleep center here at USC is that we do have a CPAP clinic that's run by you two amazing people. So give me a quick rundown. Well, what do my patients get? What do we have in our CPAP clinic? What do you do to make my patients more compliant and healthier?
They come in and we talk to them. First of all, we try to get a little bit of background. We try to ask them, give us a little bit of information as far as like, what is it that you don't like about the CPAP? We like to start there first because a lot of the times it ends up being the mask. More times than not, it ends up being the mask. When these prescriptions are sent out to these companies for the patients to get their CPAPs, they get sent a mask. Sometimes it's not the right fit. And one of the great things about a CPAP visit is that we actually try on 3 to 4 different masks.
Okay.
And it could be a full face. It could be a combination of full face, a nasal mask, and they like having those options. So that's one of the biggest things. We kind of are able to mess around a little bit with their pressures and see, we do a mask fit to see this is as high as your pressure is going to go. Can you tolerate it with this specific mask? Okay, now can you tolerate it with this different mask? So that way the patient gets to know, okay, this is what I can tolerate with this mask, with mask A, and then it doesn't feel as comfortable with mask B, but it's okay with mask C. So
interesting. So let me ask you this. I'm going to interrupt you because I have a clinical question. So let's say someone's on a fixed CPAP of, I'll make up a number, a pressure of 10. So you take that pressure of 10 and put them on a nasal mask, then a full face mask, then a nasal pillow, and see which one of those he or she tolerates better? Is that what you do?
Correct. That's correct.
We do that. We also, if they have had any compliance which sometimes they have. We pull up their compliance report. And if, for example, if it were an auto PAP, we try to see, okay, you're on 4 to 20, but you only use, your max is 8 that you've ever used. So let's go ahead and kind of pull the variation of that pressure down.
Okay.
And try to make it more tolerable for you. Also adding ramp times, sometimes taking away the EPR. That's been an interesting thing that I've been doing lately and trying them.
Oh, Chelsea, you're forgetting that you're using a lot of words that are going over his head. Like, I mean, what is an auto PAP and what is an EPR? I know what it is, but Chelsea, can you explain to the audience what are the things you're talking about?
So a ramp time, an auto PAP is what you asked.
And ramp, give me all three.
Oh, wow. Okay. So an auto PAP, everybody's airway is different and unique, and everybody requires a different amount of pressure. So that pressure, when we give an auto PAP, we can give that range from 4 to 20, and it will basically adjust to your airway if it senses you stop breathing and increase that pressure.
Nice. Yep, that's right. Auto PAP. What about this ramp? What's a ramp?
So a ramp time is something that we sometimes put on to help people adjust to CPAP. And so say that it takes, for example, somebody a half an hour to fall asleep. So I will put that ramp time on for 45 minutes, which means that it's going to stay at, say, I set it the lowest pressure till 4, so that it gives them time to fall into a deep sleep before the pressure increases or adjusts to their airway.
And people love that. People love that because it's when they get their machine sent to them, it's not a setting that is set unless the doctor specifies, and it's always just it's on auto. So the machine will do it when it feels like it needs to. But when we set it, it's set for 45 minutes. They love the 45 minutes.
They love the 45 minutes.
Yeah, it'll stay at the very low pressure, the lowest pressure for 45 minutes. That's been a huge thing.
It has. It's
especially for new CPAP users because they don't mind getting the pressure, but they don't want a lot of pressure.
Right.
So
it's been a saving grace here.
Well, and let me throw one thing out there, from a clinical standpoint, what really has a lot of strong data for compliance is that humidifier. Are we on board here, girls, about the importance of the humidifier? Let me ask you this. Do most patients know what the humidifier is? Do they know what type of water to put in the humidifier?
No, unfortunately, they do not. Some of them have no idea. They don't even know they can put water in it or what it's for, or the heated tubing that it sometimes comes with. They have no idea what that is either.
So you guys tell me, what type of water should the patients use?
Distilled water.
Yes, exactly. It's just amazing that, in my opinion, and just correct me if I'm wrong, distilled water is because you don't want to damage the machine itself. You're not going to blow up the machine if you use tap water or anything else. But, it really is distilled waters that should be used. And it really just helps out, with that air, it makes it more comfortable. Right. So, I think that's a huge part right there.
I agree with you. That's why it's great to see them in person, to be able to go over all of that stuff from A to Z.
Go over all of these things that we just discussed in a CPAP visit. And we both feel very satisfied when the patients leave our CPAP visits because they literally look at us and they're like, wow, thank you. Like none of this made sense until right now. So,
no, and I hear great comments. And how long do my patients get to hang out with you too?
45 minutes, an hour, sometimes an hour and a half.
It varies.
It varies.
Oh, really? Now, I like this statement. It was kind of like a bullet point, but the statement was they had an experience where someone had sleep apnea and the patient was using their son's mask. Wait, can you explain to me what this bullet point is?
Yes. So this was during a CPAP visit, and the patient came in and said that she did not like the full face mask that they had originally given her from the DME, and that she's like, well, this mask works so much better. It was her son's asthma mask for breathing treatments.
Oh, no.
Yeah. And I was like, this is not a mask that you should be using. She's like, well, it feels great. I'm like, you're not even getting any of the pressure. So, of course, I look and her leak is ridiculously high. So the leak, of course, meaning that the pressure is escaping from there for those that don't know. So so her leak was high. She was not getting any of this pressure she needed at night to even treat her sleep apnea because she was using a breathing treatment mask.
But the important thing here is that she was content with her mask.
She was. She was at the time. So
Takeaway.
So we had to explain why that was not a viable option for her.
So, I want to ask a couple more questions. So I'll ask this question to both of you. Since you're at the sleep center all day, you hear me talk, you have my other partners talk, you talk to patients. What is your pet peeve or threshold to determine maybe he or she should be evaluated for sleep apnea? What buzzwords do you need to hear in a nice way when you're at home or you're with a relative's house or outside to say, I think this is going to be someone who needs to be evaluated for sleep apnea? Chelsea, you go first.
Well, that's funny that you ask because I have actually diagnosed a couple of my fiance's friends that have slept on our couch.
Oh, yeah.
They've slept on the couch and I can hear them stop breathing in their sleep. And I've literally said, you have got to go get a sleep study because they're snoring and they're gasping in their sleep.
One time we were at a party, somebody fell asleep and Chelsea and I stood in front of them.
Oh yeah.
We won't say any names.
We will not.
But we stood in front of him and we literally counted while he stopped breathing for like 30 seconds.
Yes.
Shout out to him though, because he got himself a CPAP.
He did. He did. But
now I was going to say, the take-home message is 100% correct, both of you, that it's not just a snoring, is it? I know that we all think about snoring and sleep apnea, but the biggest risk factor are witness apneic episodes. If you could see someone just says, you stop breathing, buddy. And, whether it's be on your couch, Chelsea, or in Las Vegas, Lily, you're right. Once you see that is one of the biggest things. Lily, you answered the same question. What is your thing that says, I need to speak up a little bit and say, you need to get your butt tested? Is there a buzzword that you look for?
I think it's just the not breathing part does it for me. We joked a little bit about my husband snoring, but he actually has stopped breathing a couple of times. So, I'm pushing him to get a test, but that's the biggest one for me because I agree. Snoring itself is not going to, doesn't diagnose sleep apnea, but when somebody stops breathing, that they're lacking that oxygen.
I was trying to set you guys up because you put a bullet point here that I was hoping you'd bring up, and I'm going to say it because you came up with it. I like what you wrote here, that it's not normal to have excessive daytime fatigue and sleepiness. And I think that it's not normal to just feel tired all the time, and I think that it's a broad statement. There are many things that factor in, but, don't ever think that sleep at night is not contributing to what's happening during the day. That's huge. So I'm going to bring it up because you guys didn't mention that. And I love what you wrote on my paper. If you're tired all the time, you're excessive daytime sleepiness, fatigue, get evaluated, man.
Yeah,
absolutely.
Agree?
Oh, absolutely. I that's a key thing. And I think as people just ignore it, they think, well, I'm tired. I work full time and I have kids and
everything else but sleep apnea.
Sleep apnea. Any other excuse they can find.
No, and I'll tell you, when I'm in my room with my patients and they say, when I come home from work at 5:00, I just fall asleep on the couch. I'm like, I don't think that's normal.
Right.
Normal.
Right.
And we just blow it, like you said, we just blow it off because they tell us they're tired. And we're like, okay. But no, I agree. So 2 more questions. This one for each of you. As we're wrapping up the Dr. Raj show, what is your take-home message, Lily, about obstructive sleep apnea, about getting tested, just in general, about your feels about getting the right diagnosis and treatment?
I think that if you're in denial about it, just get tested, at the very least, to rule it out. Because if you feel that there's something going on, if somebody has told you, hey, I hear this a lot. Oh, I went camping and my girlfriend or a friend said, hey, you snore really loudly. But on top of that, like you were like choking in your sleep. It was kind of scary. So I think if anything else for me, it's like, just rule it out at the very least. And that can possibly lead to like a lot more health benefit than you may think.
So do you think we should bring your husband over here and give him a freebie study?
Absolutely.
And you think we could convince him that after the sleep study, we could talk about his results on the next podcast?
I'm sure he would love to.
What about you, Chelsea? What's your take-home message for everyone?
I think that if you're feeling off, if you've been feeling off, whether it's been for a few years, whether it's been for a few months, we have the home sleep study test now, which is so easy. It's so convenient compared to coming into the lab, which it just get tested. It can hurt you. You do it for a couple days, we get the results, and I don't think there's any reason not to.
Oh, I love it. And, of course, I got to ask a question to build up my own ego. How much do you guys love working with me here at the Sleep Center?
It's the best experience of our lives.
Dr. Raj is the coolest and most down to earth, actually.
All joking aside, it really is a lot of fun to be able to, come to you with questions in general when we have questions. And I know you said this earlier, you pretty much use us to practice your questions on, but we also get a lot of benefit from that. We learn a lot.
Yeah, we do. We learn so much from that. And I quote you actually all the time to other people and stuff that you say, and it does help us learn.
Yeah.
No,
you wouldn't do it if it didn't,
Yeah, kind of. Well, you know what? I think we're going to leave it open-ended so we could have both of you back later on in the year. So we could have some new topics, get Lily's husband's sleep study. So are you guys game on for another Dr. Raj podcast?
Absolutely. We'd love to.
All right. Thank you both for coming today. You guys are amazing.
Thanks for having us. Bye, Dr. Raj.
Bye.
Thanks for listening. This has been a production of Ars Longa Media. The producers for this show are Christopher Breitigan and Madison Linden. The executive producer is Dr. Patrick Beeman. This podcast is for educational purposes only and not intended for medical advice. Ars Longa, Vita Brevis.